Okay, everyone, we're going to get started, and I'm hoping everyone can hear me. We've had a few audio issues this afternoon, so why we started a little bit late. So I'd like to begin by acknowledging the traditional owners of the lands on which we meet today and pay our respects to elders past, present and future, for they hold the memories, the traditions, the cultures and hopes of Aboriginal Australia. Just a little bit of housekeeping. If you have any questions throughout the session, please pop them in the Q&A chat box. And if we have time, we will try to answer these at the end. Any questions we don't get to, I will include the answers when I send the slides and this recording out to you all. We do appreciate if you can complete the evaluation survey that will open up when you leave the session. This will help us to ensure we continue to provide relevant information for you. As I mentioned, we will be recording today's session and we'll be able to provide a copy of this recording along with your certificate of attendance and the slides. These will be sent out to the email address you registered with within the next couple of weeks. Just please be aware that each state has a different immunisation program governed by their state public health unit. So the information provided by the Queensland Health Public Health Unit may not be relevant to some people attending from other states. The information provided at this webinar is specific to Queensland, and we recommend that you check with your local state public health unit for localised information. All information provided in today's session is current as at today. Please refer to the PHU if you have any queries. Their contact phone number is 07 3624 1111. And without further ado, I'd like to hand it over to Mary Barnett, who is on secondment currently to the Metro North Public Health Unit, and she's a clinical nurse. So over to you, Mary.
Oh, hello, everyone. I just need to share my screen so that everyone can see the presentation. Can everyone see the presentation?
Yes, I can. Thank you, Mary.
Oh, okay. So thank you for attending today and taking the time out of your day. I know you're all very busy, so I greatly appreciate that you've come to join the session today. So firstly, I'd like to, Metro North Health acknowledges the traditional custodians of the land upon which we live, work and play, and pay our respect to elders past, present and emerging. So firstly, there were some questions that were sent around and some of these were the questions that were asked. So we'll go through them as the presentation, throughout the presentation. So if you have any questions, you can put them in the chat and I can answer them either today or get back to you. So firstly, we'll talk about the RSV infant program that's specific to Queensland only. And RSV is respiratory syncytial virus, and it's the leading cause of hospitalisation in infants less than 6 months of age. And infants are eligible for, it's called Nizivabab or Beyfortus is its trade name. And it's a long-acting monoclonal antibody that provides protection for at least 5 months. And so any practice that is registered with Queensland Health Immunisation Program as a vaccine service provider can administer this vaccine. It is normally given after birth, but some infants may not have actually received it at birth, and then therefore they would need to go and see their GP for that, and that's where you come in. So this is the eligibility criteria. I'll just see. Okay, that's fine. So all infants, I'll just go back. Sorry. So the eligibility is all infants born after the 1st of February this year until at least they're 8 months of age, and Indigenous infants prior to the startup program date until they're less than 8 months of age, but that would have passed by now because the startup date was the 1st of February and now it's October, so they would definitely be more than 8 months of age. And infants born with certain medical conditions up to 8 months of age, and babies with certain medical conditions from 8 to 20 months of age and until the 31st of August, and it's a catch-up program. And after the 31st of August, it's not clear exactly what will be happening. It will depend on a lot of factors. So I'm not quite sure if you're aware of the medical conditions, but I'll just bring them up. If they'll come. So this is where you can get the link to the RSV program in Queensland. And this is about infants born from the 1st of February, Aboriginal and Torres Strait Islander children, infants with certain medical conditions. So the infants with complex medical conditions are infants born at less than 32 weeks gestation and less than 12 months of age. If they've got chronic neonatal lung disease and they're less than 20 months of age. If they've got had significant respiratory conditions and such as a tracheostomy, they've needed to have non-invasive ventilation, they've got severe lung disease, or their weight is less than the 10th percentile. And if they've got severe primary immunodeficiency, and it can be at the discretion of a pediatric immunologist, less than 20 months of age, post-solid organ transplant or waiting transplant, or if they're less than 20 months of age and they're receiving chemotherapy, or they've had a stem cell transplant. That's a hematopoietic stem cell transplant, and if they've got this neuromuscular disorder. So they're the conditions. Sorry, I just have to go back. So there are some, the Public Health Unit have noticed that there have been some concerns with how the dosing is recorded in regards to RSV, and it's not always recorded on air. Not all hospitals at this stage are recording it. So therefore, but it is recorded in the infant's red book or maroon book. And so you might just need to flick through the pages just to see if it has been administered. And firstly, when you talk about the 6 medications, right, you've got to talk about you've got the right drug, you've got the right age, the weight. So that's the dose, depending on the infant's weight, is according to dose. And because it's a medication, it basically kind of requires a medication order, and you need to check the drug with the second person and ensure that they've signed a consent form. And because of their weight, depending on how the dosage is administered, you can only enter 1 dose on air at a time. You can't actually enter 2 doses on the same day. Also pregnant women can have RSV vaccine, and there's only one RSV vaccine that's been approved by the TGA, and that was in April this year, and it's called Abrysvo, and it's for vaccination of healthy women with a singleton pregnancy. It's given at 24 to 36 weeks, but it can be given beyond 36 weeks, and it does reduce the risk of severe RSV disease in infants less than 6 months by around 70%. So that's quite efficacious. It takes 2 weeks for the vaccine to be effective. So if the baby's born less than 2 weeks after the vaccine has been administered to the woman, then they need to have the infant program. And it's just a single dose IM, and it can be given with other vaccines. It's not actually funded on the National Immunisation Program, and it's on a private script. So this is, if you've ever seen the vaccine, I'm not quite sure if anyone has actually administered it, but I thought I would put this here just to bring it to your attention that there's specific preparation involved in the vaccine. Like, it becomes with this vial adapter that you have to stick onto the stick here where I'm pointing, and that's the vial adapter. Then you have to put it over the vial, and then you have to withdraw the constituted vaccine. So just bring it to your attention to read the packaging instructions about how to prepare the vaccine, because it's very expensive, and if it's private, you want to make sure that there's no wastage. The next one is, so adults, older adults can also have RSV vaccine. They can have the same brand as pregnant women, and they can also have Arexvir. And they're approved by the TGA for adults over 60 years of age. And according to the Immunisation Handbook, adults are 89% less likely to develop RSV and 85% less likely to require hospitalisation as a result of an RSV infection. There's no brand preferences, even though it's recommended for adults over 60 years of age. It's more, there are recommendations for people over 75, people aged 60 years of age that increase their risk for RSV. So that would be people with cardiac conditions, respiratory conditions, if they're eligible, if they're fit enough and well enough to have vaccines, if they're on chemotherapy. All Aboriginal and Torres Strait Islander persons over 60 years of age, and adults between 60 and 74 years of age can consider it. And it's a single dose IM, and it's, as I said before, it's on a private script. And because it's a new vaccine at the moment, it is known that the infection is not long. The immunity from the vaccine is not long. Well, immunity from the infection is not long lasting. So those who've received an RSV infection can receive the vaccine. That's what I was trying to say. Even if you've had a prior history of RSV infection, you can still be vaccinated. So we'll talk about pneumococcal vaccine now. So pneumococcal vaccine is recommended for all infants and children less than 5 years of age, children, adolescents, and adults with risk conditions for pneumococcal disease, all Aboriginal and Torres Strait Islander people more than 50 years of age, and non-Indigenous adults greater than 70 years of age. And Prevnar 13 is currently the funded vaccine, but people can elect to purchase on private script 15-valent pneumococcal vaccine or 20-valent pneumococcal vaccine, which gives additional protection, obviously, of 2 and 7 serotypes. So I've just got an overview here of these pneumococcal vaccination recommendations, just in a graphical form. So this one here is all Indigenous children, and they're recommended to have Prevnar 13, and it can be given dose 1 at 2 months. It can be given at 6 weeks, then dose 2 at 4 months, and then dose 3 at 12 months. And for children who are Aboriginal and Torres Strait Islander, or children with medical risk conditions, they're recommended 4 doses of Prevnar 13. So dose 1 at 2 months, then dose 2 at 4 months, dose 3 at 6 months, and dose 4 at 12 months. And then I have a dose of Pneumovax 23 at 4 years of age, and then a second dose at least 5 years later. So this is a current recommendation. It's always subject to change, so I should always consult the Australian Immunisation Handbook and the Queensland schedule. So children who are greater than 12 years of age, and adolescents and adults who are diagnosed with a risk condition, they're to have a single dose of Prevnar 13 at diagnosis, and then 12 months, up to, it can give it 2 months after a dose of Prevnar 13. You can give Pneumovax 23 or 2 to 12 months after Prevnar 13, or at age 4 years, which is ever later, and then a dose 2 at least 5 years later. So I'll just show you these risk conditions here. So a previous episode of invasive pneumococcal disease, so they did quite well in hospital if they've got functional or anatomical asplenia, so they don't have a spleen. They've got some immunocompromising conditions like congenital acquired immune deficiency or isolated IgA deficiency, if they've got any hematological malignancies like leukemia, solid organ transplant, if they've had a stem cell transplant, HIV infection. It's not funded for people who are on immunosuppressive therapy when they have sufficient immune reconstitution for the vaccine response. They're not eligible, and non-hematological malignancies are also not eligible as here. If they've got a cochlear implant or an intracranial shunt, they're eligible. And if they've got bronchiectasis or cystic fibrosis or chronic lung disease in preterm infants, and these like severe asthma or fibrotic lung disease or COPD are not funded, but they still can have the vaccine. It's just would be on a private script. If you've got relapse, chronic renal disease, these 2 categories, congenital heart disease, but only for children who are less than 5 years of age, any person born less than 28 weeks of age up until less than 5 years of age, and anyone with Down syndrome like trisomy 21 less than 5 years, and the remainder of the conditions are not funded. So this next category is the Aboriginal and Torres Strait Islander adults who are greater than 50 years of age. They get a single dose of Prevnar 13, and then they get Pneumovax 23, 2 to 12 months after the Prevnar 13 and dose 2, at least 5 years later. And non-Indigenous adults greater than 70 years of age just get a single dose of Prevnar 13. So pneumococcal vaccination catch-ups, there's a number of factors that are utilised to determine what vaccine to give and what doses, how many doses. So it depends on where they live in Queensland. If they're of Aboriginal or Torres Strait Islander descent, if they've got a medical risk condition, the number of pneumococcal doses previously received, and the current age of the person, and at the age at which the previous doses were administered. There's a catch-up table in the immunisation handbook. So you can look it up, or you can look it up, or you can consult the public health unit. We're going to do an exercise later on, but with Prevnar 13, it appears as this white milky solution when it's packaged and then when it's delivered. So, and it needs to be actually shaken for 30 minutes. So if you're a fan of Tay Tay, you can think of her song, Shake It, and shake it for 30 seconds. And after that, it should have be a uniform whitish suspension. And then you actually need to shake it before you administer it. So this is a good way to remember. And if you're not a Tay Tay fan, you can maybe think of some other thing to prompt your memory to remember to shake it. So this is a catch-up example. So this is Mika. She's a 10-month-old infant, lives in Windsor. She's Aboriginal descent, recently been in hospital with invasive pneumococcal disease, and they're up to date with all their other vaccines, except for some reason they only got 1 dose of pneumococcal vaccine 13 at 2 months of age. So going on as principles before, we know the child's age, we know that they're of Aboriginal descent and they've got a risk condition, and we know all this information here. So what is the recommended catch-up for this child? For ease of time, I'll just go through this. So I'll just go through this table here. This is the table here, catch-up schedule for pneumococcal vaccines for Aboriginal and Torres Strait Islander children living in Queensland. So this is our child, Queensland. They're Aboriginal or Aboriginal descent. They're less than 5 years of age, and we know now that they've got a risk condition for pneumococcal vaccine. And so pneumococcal disease, I should say. So the number of doses they received already is 1, and the child's less than 12 months of age because the child's 10 months of age. Mika, age at first dose, it doesn't really matter when it was given, but we know it was given at less than 12 months of age. Well, it's not applicable because they've only had one vaccine, and the number of, so the primary doses is 2, and the number of booster doses at greater than 12 months of age is 1. So the child will get 3 additional vaccines. So this is a handy little table to refer to when you're doing a catch-up, and you can just go through these principles like number of doses already given, the age of the child, do they have any medical conditions, and when were the vaccines, the pneumococcal vaccines given. And then this is a table on the minimal intervals, which is also handy to look at when you're calculating a catch-up schedule, because on the previous table it said that this child needed 2 primary doses and a booster dose at greater than 12 months of age. So the minimal interval between dose 1 and dose 2 is 1 month. So we would give dose 2 today, and then the minimal interval is between dose 2 and 3 will be 2 months. It must be greater than 12 months of age. So it will need to be 2 months of age. 2 months is the interval for the next vaccination. So there's other examples here that you can look at. So there was a question about funded vaccines for specific age groups. And this is it. There's COVID vaccines. There is 5 to 64 years of age is a Queensland program of influenza. Any Indigenous person or with medical risks, it's a funded vaccine through the National Immunisation program. Persons born after 1966, if they don't have 2 documented doses of MMR vaccine, they're funded vaccines, and pregnancy, either Adacel or Boostrix or influenza. There's the Shingrix, which is provided by the National Immunisation program, and recently there's been a significant change to who is eligible for Shingrix vaccine. So I'll just go through that with you. Oh, okay then. So this is program advice for health professionals. So from September this year, the availability and recommendations for shingles vaccination was changed, and it's a more broader program now, and it includes people at moderate to high risk of severe infection and complications from shingles, because they can get post-neurologic disorder with ongoing pain. So if they have 2 doses, that is eligible for 65 years and over, Aboriginal and Torres Strait Islander people 50 years and over, eligible people 18 years and over who are considered at risk of shingles due to underlying conditions. So the eligible, and there's a difference in the dosing schedule according to what condition a person has, so, or the eligible group. So someone over 65 years of age and Aboriginal and Torres Strait Islander people over 50 years of age, the dosing interval is 2 to 6 months apart. However, people who are over 18 years of age with increased risk due to their underlying medical conditions, the intervals are 1 to 2 months. So I'll just scroll down here. And there's a huge list of who is eligible for Shingrix vaccine. So it's quite exhaustive. And so I won't go through it. I think it's something to read and then think about what patients you have and whether or not they, and in working with their treating team, as in to give the Shingrix vaccine. So as you can see, it's quite expensive. So it would be something that you would need to have a look at and apply to your patient cohort in your practice. And there's special risk groups like Japanese encephalitis virus vaccine. That's mainly for people who work in laboratories or people who are doing surveillance for mosquitoes. And then refugees and humanitarian entrants greater than 10 years of age are eligible for a single dose of Boostrix and then 2 doses of ADT, or they can have 3 doses of this. They're eligible for chickenpox vaccine, and it depends on their age, whether or not you would be giving them, and their medical conditions, depending on if you would be giving them Shingrix or varicella, polio, measles, mumps and rubella, Hep B and HPV. And HPV can give up a single dose up to 25 years of age. And in regards to these vaccines here, medical at risk are these additional vaccines. And if you start a teenage catch-up schedule before 20 years of age, you can continue to complete the series. So this is just an overview from a visual perspective. So this is the National Immunisation Program funded vaccines. This is in addition to the schedule, the immunisation schedule for Queensland. These vaccines are also recommended. Aboriginal, as I said before, measles, born during or since 1966, pertussis in pregnancy and year 7, and COVID-19 according to the current recommendations. And we've discussed Shingrix and we've discussed pneumococcal vaccine. And I'll go into Mpox in the next slide. And the next one is meningococcal vaccine, like Bexsero, is for children with medical conditions at less than 5 years of age, or Aboriginal and Torres Strait Islander children less than 5 years of age. And meningococcal vaccine, as you know, is given on the schedule at 12 months. And this should be year 10 for meningococcal, ACWY. Sorry. But this bit here was meant to be up here, but something happened when I did this slide. So year 10 for men, ACWY, Nimenrix, and there has been another vaccine that is able to be used called Mencoffee. So that can be used as well. HPV for year 7 and less than 26 years of age, and catch-up is for less than 20 years of age, and specific vaccines for greater than 20 years of age, as I described before about refugees and humanitarian entrants. And so this is the Queensland Health funded vaccination program. So at this stage, influenza can be given to children greater than 6 months of age until the vaccine expires, which is generally, some of them expire in December, some of them expire in January, and some of them expire in February. And as I discussed before, the Queensland meningococcal B vaccination program is infants 6 weeks to less than 12 months and a catch-up for children 12 months to less than 2 years of age who have not yet started or completed their MenB immunisation with Bexsero, and adolescents who are 15 years of age, so generally that's year 10 to less than 20 years of age. So this is a specific Queensland Health immunisation program schedule, and as I discussed before, the RSV program. So the next slide is about Mpox. I'm not quite sure if anyone is how familiar everyone is with Mpox. It used to be called monkeypox virus, but the World Health Organization changed the name to Mpox. And it's caused by an Mpox virus, and it's very similar in the same family as variola virus, which causes smallpox and vaccinia. So they're all in the same family, and it has similar symptoms to smallpox, but generally milder. And people with Mpox tend to have lymphadenopathy, and that's not characteristic of smallpox. And most people recover in 2 to 4 weeks, and there's 2 types of Mpox, what we call 2 clades, and it is clade 2 that is circulating in Australia and in various parts of the world, and the first clade is clade 1, which is basically confined to the Central Africa, like the demographic Congo. And it's most Mpox cases in Queensland are in the gay and bisexual and men who have sex with men community. So they're the highest proportion of groups that who have Mpox in Queensland and in Australia at the moment. And some of the factors, it's really important to promote immunisation in this group because there's not all persons who belong to, who are GB and SM are aware of the availability of the vaccine. And anyone, so this is the vaccine, it's called Genios. It's a live, non-replicating virus, so it can't reproduce in human cells. And it's effective at preventing Mpox. It's been brought into Australia under the Therapeutic Goods of Australia Act, and they've made it via a special emergency pathway for the prevention of Mpox. And 2 doses are needed to be given at least 28 days apart. And at the moment, no booster dose is recommended. And if a person has Mpox and they want to be vaccinated afterwards, the guideline, there's actually no formal recommendations, but it needs to consult with the public health unit in regards to, could be 6 months, but we just get some further advice on that because it's changing in this area. So if you want to become an Mpox vaccine service provider, you just need to send an email to QUIP and they'll tell you how it happens, and then you can order the vaccine. And Queensland Health has set up this Mpox vaccination centre quick finder. That's why you need to register to become a service provider, and because this is what happens. It talks about Mpox here on the Queensland Health thing webpage, and this is where people can put in their postcode and search on the radius, and it will give you where there's vaccines available. So that's why you have to register. So and it's funded for eligible groups, including Medicare ineligible people. So there may still be a fee associated with the consult, but the vaccine itself is funded regardless of a person's Medicare status, whether they have a Medicare card, whether they don't have a Medicare card, they've got a different coloured Medicare card, they've never applied for a Medicare card. It doesn't matter, they can all have it if they are telling you that they're in a at-risk group. And so with the Jenios vaccine, there's certain vaccines that are legislated to be on the Australian Immunisation Register. And all the other vaccines are strongly recommended to put them on the register. However, when you're vaccinating someone for Jenios vaccine, you just need to get their consent that to record the fact that they're getting Jenios vaccine, and because it will be visible to other vaccine service providers, and they may not wish to disclose that they've had Jenios because of their particular group that they belong to, and they may have some privacy reasons for that. So that's acceptable. It doesn't have to go on, but you would just need to give them a vaccine, their own vaccine record card, so that they have a record of the fact that they've been vaccinated. And they could decline vaccine because they've been vaccinated before. So this is the recommendation for people of all age, including sexually active gay, bisexual, or other men who have sex with men, sex workers, people living with HIV if they're at risk of mpox exposure, and laboratory personnel working with orthopox viruses. I mean, it can be considered for healthcare workers who are looking after patients with mpox, or sexual partners of gay and bisexual men, and the sex workers and people living with HIV. Currently, it's no eligibility for funding for people travelling to areas where mpox is circulating, and the only way that the vaccine is actually only available through Queensland Health. It's not available on a private script, so they don't actually meet current vaccine eligibility. It's not recommended. So this is what I was talking about before, endemic parts of Africa, like the Democratic Republic of the Congo, and that's where this more virulent strain, Clade 1B, is circulating. So what's new? There's always something new. So you may notice a change next year with the flu vaccine. You may notice that it's gone from quadrivalent to trivalent. The World Health Organization recommended that the vaccines become trivalent. It actually happened last year, but a lot of manufacturers had already manufactured their vaccine, so they just proceeded. And so the reason why that it's not actually recommended for a quadrivalent vaccine, so we're going back to trivalent, is because this is a wordy document. So we're transitioning from quadrivalent to trivalent. And the reason why is because of this B Yamagata, which is not really causing any disease in humans anymore since COVID. So it'll have 2 A's, the trivalent vaccine, and 1 B vaccine. So this is quite wordy. You would have to have a look at it. So if you look here, there's these vaccine efficacies that they have looked at. So 6 months, looks at the vaccine efficacies and why this decision was made to change. So it's a big document. You can have when you get the presentation, you can have a look at that, but you may still get quadrivalent. It depends on exactly what's going to happen. So there's that. Why? I talked about that before. It's not circulated for several years, and from 2026, it will be exclusively a trivalent vaccine. Shingrix, I've talked before about Shingrix in regards to the change in eligibility and why compared with immunocompetent people who are immunocompromised have higher rates of shingles and complications, and shingles can still occur at a younger age in people who are immunocompromised, and there's a higher risk of reoccurrence. And as I said before, those people who are immunocompromised, the scheduled dosing is 1 to 2 months apart. So there were some questions about parents, and we get this quite often through phone calls, is early vaccination. So what do you do? So there's lots of different scenarios, lots of different countries they're going to, how old the child is. So here's an example here. So the family is traveling overseas and they'd like to have their 2-month vaccinations early. Yes, they can. That can be done, provided that this minimal interval has been met. And so we need to refer to the handbook in regards to minimal intervals, which I think I had up before, and you'll be able to have a look at it when I send you the presentation, because the link will be there. I can't actually access it at the moment because my Zoom thing is there. I can't actually do it for you. So this is the reasoning here. It's a bit wordy, but you can have a look at it at your own leisure. And then you need to provide further advice once this situation has occurred. You need to have a look at the minimal intervals between the first and the dose that they've just been given early and the next dose, so that the intervals are met, because you need to meet the minimal intervals for the vaccine efficacy. If they're traveling overseas before 6 months, they can have the vaccine before the 2-month interval, but they need to recognise that their child may not get adequate hepatitis B protection, and then they'll need to have a monovalent dose of hepatitis B vaccine, which is not funded. It needs to be purchased privately. There's so many scenarios that it's hard to go through them all. So there's one here. The next age point is 12 months, when the MMR, the meningococcal, and the Prevnar 13 are due. They can be given prior to 11 months of age. However, they won't be recognised as valid on air, and they'll need to be repeated at 12 months of age. And so that's not a reason not to give them. If someone's travelling to a country where there's a high incidence of measles, you would consider giving it. If they're travelling to those countries, and meningococcal AZWY can be given before 6 months of age, and they've already had 2 doses of Prevnar 13, so another dose is not, they can have it at the time of travelling, or they can wait. It depends. There's lots of factors involved, so you most probably always need to seek some advice on this. And the meningococcal measles, mumps, and rubella vaccine, measles, mumps, rubella, and varicella vaccine. It's scheduled for 18 months of age, but it can be given earlier, provided all the minimal intervals have been met. So active, it's 2 months, and for Infanrix, it's 6 months. So you just need to have a look at what these minimal intervals are before making a plan and administering the vaccines. Otherwise, they're invalid, and then the family need to, the child needs to be revaccinated, ideally 2 weeks before. And if they're traveling to countries, they must probably, other countries where there's other endemic diseases, they must need to think about a travel consult. So we'll talk about vaccine errors. Vaccine errors do occur, and as you would be aware, there's a reporting system for vaccine errors now, so that these can be monitored, and they can have a look at what the reasons are as to why these common mistakes are occurring. But these are the 6 medication rights. Got the right patient, the correct birth date, and the correct age of the child. It's got the right vaccine for that scheduled point according to the child's age, and on the NIP schedule, and the correct route of administration. So some vaccines are given IM, some vaccines are given subcutaneously, and some vaccines are given oral, but that's only Rotarix at the moment. And if you feel like it's not comfortable, this child shouldn't really be having this vaccine, then you've got the right to refuse if it's outside your scope of practice, and you need to have a discussion with the doctor that's ordering it. And I forgot to mention before that Mpox vaccine is now given subcutaneously, so it can be given by any practice. Initially, there was a short supply of the Jenios vaccine. It was given intradermal, but now there's ample supply and it's given subcutaneous. So any vaccine service provider, if they've registered with CRIP, can administer the Mpox vaccine. And there's just some points here. If you've got a few vaccines that you're reconstituting, it's a good idea to have them in separate kidney dishes, just so that the diluents don't get put into the wrong vaccine, or the wrong vaccine doesn't get put into a pallet. All of those things that need to be considered. So it's all about workflow and check before administering. So that's all about procedural ID checking, which is Australian standard. So what do you do if it happens? We understand that these things do happen, and the most important thing is that is counselling the family and ensuring that the child is well, and if there's any further action that needs to happen. So, and you can look at, sometimes the flu vaccine is given too early, and then you need to get some advice on what happens with these vaccine errors. So and contact the public health unit. Need to advise them on some possible reactions that are likely to happen, follow up, have a look at your own processes in regards to how this happens. So we operate from this blameless culture where we're trying to identify systems and processes that occurred that led to the medication error. And that's what the Australian government is looking at. And still upload the vaccine to the Australian Immunisation Register. It'll just appear, it'll ask you to confirm the dose, and then you'll confirm it, and it'll have a message on there, minimal interval not met. And then if you could complete an adverse event form and click, there's a box on there for vaccine administration error. Need to tick that so that they can be monitored and information reviewed. So what about Medicare? So as I said before, anyone can have a Jenios vaccine for Mpox if they meet the eligibility criteria, and having a Medicare card or not having a Medicare card, or whatever colour Medicare the card they have, is not a contraindication to giving Mpox. But essentially, if most of the National Immunisation Program vaccines are according to Medicare, and if they're at school, they're eligible for all of the National Immunisation Program visitors. So if you have a family that just jetted over from China for the weekend and they want to have some Australian vaccines, they're not really eligible. And most overseas, this is a concern, most overseas students studying in university are not eligible for NIP vaccines unless there's a reciprocal healthcare agreement. And you would need to create an air record for them so that the information is recorded. And when the parent applies for a Medicare card, the information submitted by the parent will match with the vaccination information, so that they will populate the child's vaccination record behind the scene. So vaccination reminders, there's 2 doses. So this is about measles. so there's 2 doses on the National Immunisation Program, one at 12 months and one at 18 months. It's funded if you're born after 1966, and the minimal interval is 4 weeks. But if someone says they've had 2 doses, if there's no record, try and encourage vaccination. But if they come to you and they were born in 1952 and there's no record of vaccination, we presume that they've had wild measles infection and they don't need to have vaccination unless there's any other evidence that supports that. But you wouldn't do serology testing because you would assume that they were already immune if they were born before 1966. It can give an MMR vaccine from 6 months of age. It's given in lots of countries where measles is endemic. However, the child would need to have repeat doses at 12 and 18 months of age, and 1 dose would not be funded. It would need to be a private purchase. And it doesn't have to be repeated if the child was 11 months and 1 day, or more than 11 months of age. So varicella is 1 dose of varicella containing vaccine is at 18 months of age, and between 12 months and 14 years of age, it's only 1 dose schedule. You actually need 2 doses to have full protection, but only 1 dose is funded. And you should counsel families on that, like this 1 dose here that you're receiving is funded, and then if you wish to have another dose to fully protect your child, it would need to be on a private script. So if you give, sometimes this can happen, if MMR vaccine is inadvertently given as dose 1 of the measles containing vaccine at 12 months, the child should still be given a 2nd dose of MMRV vaccine at the 18-month point of period. It's because you can have a look at here when I send you this information. Likewise, if a child from overseas has varicella vaccine and still has an MMR, but still requires they still require the 18-month MMRV, even though they've already had a VZV vaccine, they still are eligible for one of the either Pryrix or Tetra or ProQuad as per the Australian schedule. Okay, so these are some of the questions that were submitted. Do I need to restart the course after an extended period of time? Like I had 1 dose of, say, measles, mumps and rubella, and they were 13 months of age when they got it, and the parents didn't give any more vaccines, and they came back at 5 years of age and say, okay, we want a measles vaccine now. You don't need to restart the schedule. Just need to look at their immunisation history just to make sure it wasn't given and the parents don't recall. And the only vaccine that's, that is that you need to restart the schedule for is cholera vaccine. If the interval is too short, another dose should be given at the correct interval from the previous valid dose. Record all doses on air and ensure that you put in the correct dosing number when you're doing that. Do you need to wait 4 weeks between 1 inactivated vaccine and a live vaccine? So you give Prevnar 13, and the child's also due for MMR vaccine. There is no minimal interval between this situation here. It's if you give a live vaccine, there's 2 live vaccines, there needs to be a minimum of 1 month between, or 4 weeks between doses. And if it's the same antigen, then you need to follow the minimal intervals. So these are the live vaccines: MMR, MMRV, Pryrix, Tetra, varicella, BCG, yellow fever. Yes, and there's some Japanese encephalitis vaccines that live attenuated. So this is the Bexsero intervals. So you can see that this is from the handbook. So 6 weeks, I should say, to 11 months Bexsero. You get 3 doses, 8 weeks between first and second dose, and the third dose at 12 months of age or 8 weeks after the second, which is ever later. And 12 to 23 months of age, there's 2 doses and they're 8 weeks apart. This is the information that I presented before. Have a look at that at your leisure. So here's some questions that we've received about Bexsero vaccine or meningococcal B vaccine. A patient has had 2 privately funded Bexsero vaccines at the age of 12, and the parent has requesting advice on whether they should have the year 10 Bexsero vaccine. Yes, they can. But a 2-dose course at this time is seen as being unnecessary, so they just need a single dose. Or the parent may wish to delay until a 5-year period is reached, and that's fine. And the next one is there's no recommendations for a booster dose of Bexsero in this age group, but if parents choose that they need to have it, it's just a single dose if their child has already received a schedule. And however, it's different for people who are asplenic. There's a 5-year interval for Bexsero vaccine. Can you give men the vaccine in pregnancy? Generally, no, you can't. They can if they're at increased risk of meningococcal disease, but there's limited data on the safety of meningococcal conjugated vaccines, where there's other ways in which if pregnant women have been a contact of a meningococcal case, there's other prophylaxis, antibiotic prophylaxis that can be recommended. So overseas schedules, parent wanting to vaccinate OS before they're returning, they can, you need to vaccinate according to the Australian schedules. They want to customise their vaccination schedule. Well, for example, if they want to have Immunisation IPV instead of Immunisation Hexa, it is permissible to do that, but you'll counsel them on the missing antigens like the hepatitis B component and the Haemophilus influenza component of the vaccine. So there's product information, and then there's information in the Australian Immunisation Handbook, and they're not always the same. So it's important to always look in the Australian Immunisation Handbook, because the information has been reviewed by the Australian Technical Advisory Group on immunisation. So the handbook is the standard to look at. So I discussed this before in regards to what the different vaccines are, whether there's a NET vaccine, antenatal vaccine, private and state. So private's pretty easy because they paid for it. State vaccine, that would be, as I described before, about the influenza program, the RSV program, and the meningococcal, that would be a state vaccine. And antenatal, well, they're pregnant, they're getting Boosterix or Adacel or influenza. So there's, and also the ADT in, the ADT in the doctor's bag is a private vaccine, so it can be entered into air as a private vaccine. And then, on air it talks about how it was administered, etc. So you just need to complete those fields and the batch number. And finally, if you want to look at doing some further training in regards to immunisation, there's it's a free course and it's provided by Queensland Health, and there's 4 components of it, like vaccine development and safety, the National Immunisation Program, talks about vaccine administration and vaccine management. So there's something to work through and increase your knowledge and skills in regards to vaccination. And these are my references. So are there any questions?
There is. Sorry, Mary, you can hear me?
Yes.
Yeah, excellent. There are some questions, but what I might do is leave those
Yes.
and I'll send them to you and get you to answer them for me, and I'll send it out to everyone. I would like to thank you, Mary, for the presentation today, and thanks to everyone for your patience with our technical issues this earlier.
Yes.
Just remember, there is a survey that's going to pop up once you leave the session here this afternoon. If you can complete that, it is always very helpful for us to just check where we're going with these webinars. And yeah, I guess we'll leave it at that. And certainly, if you have if you've put a question there and you need an answer quite urgently, please contact PHU directly. As I said earlier, their number is 3624 1111. But otherwise, I will get those answers out with the slides from Mary and your certificate of attendance. So, and I can see somebody's got their hand up. Amar, if you can put your question in the Q&A, I'll get that out to the PHU to respond. Okay, thank you so much, Mary, and we'll see you all next time.
Yeah, thank you for everyone. Sorry, it's very didactic. It's the type of webinar it is. So, okay, just remember to shake that Prevnar 13 vaccine. Thank you. Bye.
Thank you. Bye.